Good afternoon. So it's my pleasure to present the news symposium. The title is Improving Health for All the People, a New Era of Change. I'm Mario Barbagallo. I'm the president of the EAGG-ER, the European Region of International Association of Gerontology and Geriatrics. And we're going to have three fantastic speakers today. The first one is Professor Timo Strandberg from Finland. He's also the chair of the EAGG-ER, the chair of the clinical section of the International Association of Gerontology and Geriatrics. And he will give a lecture on healthy aging in the 21st century. The second speaker is Professor Karin Andberg-Randberg that will give a lecture on using digital health to embed geriatric medicine in primary care. And the first speaker of today is Professor Tahir Masood, president of British Geriatric Society, that is also the main organizer of this fantastic symposium that will give a lecture on strategy to combat the burgeoning global issue of loneliness and its adverse effect of health. The first speaker is Professor Timo Strandberg. Timo, go ahead.
Ladies and gentlemen, I'm Timo Strandberg from Helsinki, Finland, and I'm going to tell you about healthy aging in the 21st century. Here are my disclosures. For healthy aging, I think it requires three things: nature, nurture, and good luck, which means avoidance of accidents. Like in this fruit game. And I'm going to give you 12 tips for healthy aging, and it's a courtesy to Dr. Albert. 14 years back, he presented something like this in American Journal of Medicine, but I have modified these tips for today. And first tip is genetics. Of course, if you can get long-living parents, it would be very good, but routinely it's difficult, at the moment at least. But anyway, if you have been lucky for genetics, your possibilities, or if you are not lucky, your possibilities may be reduced if you neglect the following 11 tips. And the second one, don't smoke. Never start smoking, and if you have started, stop. And here you can see from the Helsinki Businessman study how many years you lose of your life if you smoke. Third one, very important, physical activity. Well, you can say that only exercise on the days that you eat, so that means that you should exercise every day. But it is the physical activity rather, which is the thing, not the clothes or shoes you are wearing. Take stairs, walk, avoid elevators and e-scooters nowadays. And of course, jogging is okay if you like it, but regular physical activity in everyday life is the most important thing. So I think very recently in the European Sprint study, which was published a couple of weeks ago in the British Medical Journal, it showed that physical activity and nutrition, good nutrition, helps to prevent mobility disability. And of course, that's very important in old age for autonomy and independence, that you have mobility. Fourth tips is about diet. I can say that you should avoid fat diets. They are not needed. Extreme diets, they are useless. Of course, they may work in bred mice of laboratory experiments, or of course, very extreme diets may work in some animals like the tortoise presented here. But anyway, I'm Keynesian in the way that I think the Mediterranean diet is a very good example of a healthy diet, and there are very good randomized trials about the effects of and good effects and benefits of Mediterranean type diet. And Answer Keys, who was an American nutritionist, he lived up to 100 years, and he followed his wife's good advice over 60 years ago, which are presented here. Some very important points are marked in red: restrict hard saturated fats, prefer vegetable oils, you should change saturated fats for vegetable oils, favor fresh vegetable, fruit, and low-fat milk products, avoid heavy use of salt and refined sugar. Sixth tip: avoid obesity. Don't get fat during your life course. Of course, it may be okay to get some overweight after midlife. It's not healthy to lose weight when you are older. But still, I don't actually believe in the obesity paradox, and I think that keeping your weight in check over your life course is the best option. And of course, it's very important to separate intentional and unintentional weight loss in this aspect, and also for the obesity paradox. Seventh tip: drink alcohol moderately or not at all. Drinking alcohol is not needed for longevity, but as a doctor, I give this as medical advice. Of course, there may be very different various beneficial effects of alcohol, moderate alcohol use in social circumstances. But anyway, alcohol is not needed for prevention of dementia and so forth. Eighth tip: take your preventive medications. Take your statins, antihypertensive if they are indicated. Lifestyle modification is good for population, but it's not necessarily sufficient for individuals. And I also think that the sensible screening of risk factors is beneficial, certainly. And as an example, I always shown this example of the flying Finn, Paavo Nurmi, who won 8 Olympic gold medals. He exercised, he was slim, and still he experienced his first myocardial infarction when he was 61 years of age. And I'm sure that Paavo Nurmi had a cholesterol problem. Ninth tip: avoid loneliness. Keep up social relations. Family, friends, they are very important, and if you are lonely, a circle of friends, you can find information about this activity on this video and shown here, and the address. Enjoy conversation, enjoy dining, recreation with people you liked. For example, your spouse is very important for that respect. And avoid people you don't like if that's at all possible. You can also refer further to tip number 12. 10th tip: leisure and hobbies. Cultivate an avocation that occurs away from your working day. For example, playing a musical instrument. Music is very good for you and for recreation. Engaging in sports you like, golf or tennis, whatever, reading interesting books and so forth. And even better, if you can do your hobbies and leisure activities with someone whom you like. 11th, be cognitively active all your life. Be informed, but try not to be overwhelmed by Twitter, Facebook, and We know that many daily news are comprised comprised of negative stories. Of course, they make news and all kinds of celebrity updates. I think it's far better to spend the time doing what is suggested in previous tips for exercise, friends, and hobbies. And also having less screen time, whatever TV or computer or tablet can help you with tip 6, which means preventing obesity. And 12th tip, avoid unnecessary stress. Take it easy. And of course, don't even stress yourself with these 12 tips. Try to put things into perspective and don't stress too much with these steps, as I said. If you manage 8 or 9 of them, that should increase your possibility of having a longer, healthier, and also a happier life. Thank you very much for listening and seeing, and my warm greetings from Finnish summer and midnight sun. Thank you very much.
Next speaker is Professor Tahir Masood, President of British Geriatrics Society from UK, that he will give a next lecture on strategies to combat the burgeoning global issue of loneliness and this adverse effect on health. It's a very crucial issue, and we are happy to listen Professor Masood. Tash.
Hello, dear colleagues. I'm going to talk today about a growing worldwide problem, the issue of loneliness in older people. Before we start, I think it's important to think about the terminology. Social isolation and loneliness are, of course, related, but they're not the same thing. Social isolation is an objective state of having minimal contact with older people, whereas loneliness is the subjective state of perceived isolation. In other words, a feeling that a person lacks relationships, closeness, and interaction. Studies from different countries suggest that up to 1/3 of older people suffer from loneliness at some point. Data from the UK suggests that 5 to 16% of people over the age of 65 years experience loneliness most or all of the time, and 30% experience loneliness sometimes. More than 75% of GPs in the UK report seeing between 1 and 5 lonely people every day. So it's a big problem. Data from 25 European countries suggest that, in fact, there is a U-shaped curve in the relationship between prevalence of loneliness and age. So the highest prevalence of loneliness appears to be in the younger age group and the older age group. But of course, loneliness can be a problem across all age groups. Now, there are certain life events that can make us feel more likely to feel lonely. Some of them apply across all age ranges. So, for example, bullying, losing a job, becoming divorced, or relationship breakdowns. However, there are some factors which are particularly relevant for older people. And these include bereavement, retirement, moving into care, living with disability, and entering a period of poor health. Now, in terms of how we measure loneliness, I would commend to you an online data from an organization called the Campaign to End Loneliness, which is a UK charity which deals with the issue of loneliness. And they've summarized commonly used measurement tools as listed here. And they go into details about the pros and cons. So, for example, there is a Campaign to End Loneliness measurement tool, which has 3 questions. Number 1, then there is the single item scales, number 4, and these can be particularly useful to a screening for loneliness in older people, in hospital maybe, or in their own homes. And then there are more complex scales, such as the De Jong-Gierveld Loneliness Scale or the UCLA Loneliness Scale, which are particularly useful for loneliness research. What about the consequences of loneliness? We've established that it is common in older people, but there are adverse consequences. So firstly, there can be adverse psychological consequences, including increased prevalence of depression, suicide, cognitive decline. There can be increased adverse physical consequences, such as cardiovascular disease, increased risk of stroke, and increased mortality. It is associated with increasing frailty, which can lead to motor decline and functional decline. And of course, loneliness is also associated with increased cost to society in terms of increased use of emergency services, increase in GP appointments, and increase in care home admissions. So the consequences of loneliness are far and wide and important. Now, of course, currently we're in the decade of healthy aging, the WHO and the United Nations initiative, and this is an excellent report, which I will also commend to you, Social Isolation and Loneliness Amongst Older People. And this report outlines the interventions and strategies to reduce social isolation and loneliness. Now, this can be on the left at an individual level and relationship level interventions. This includes one-to-one or in groups. It could be digital or face-to-face. And examples include social skills training, psychoeducation, befriending schemes, social prescribing, cognitive behavior therapy, and mindfulness. Then there are community level strategies in the middle, such as improving infrastructure. In other words, providing better transport to let people to travel to their connections, better digital inclusion, better built environments, the role of volunteering, and developing age-friendly communities. And then on the right, there are more societal level strategies. And examples here include developing laws and policies that address, for example, discrimination and marginalization of groups such as older people. It addresses socio-economic inequality. It bridges the digital divide. It increases social cohesion and improves intergenerational solidarity. Now, in the UK, a collaboration effort between two organizations, the Co-op and the British Red Cross, has set out a pathway for connecting communities to tackle loneliness and social isolation. This includes going from left to right, identifying older people who are lonely or at risk of being lonely, and then having a personal or a person-centered conversation with them about what's important to them. And then by providing tailored support to make these connections, with the eventual aim on the right of making them independent in terms of having these connections. Now, at the heart of this are the connector schemes, and these have different names and different types, and these include social prescribers, local area coordinators, village agents, mentors, community link workers, and sometimes they are called navigators. There are challenges, and what you need to know is local knowledge and connections to find the right support for people in all their diversity. So forming a database of what's available can be helpful, but of course the challenge is keeping this database up to date. Now, in the UK, a few years ago, the government decided to do something about this important issue of loneliness. And they came out with this strategy for tackling loneliness called A Connected Society. Theresa May, when she was Prime Minister a few years ago, appointed a Minister for Loneliness. And as far as I'm aware, this was the first country to appoint such a minister. Some initial funding came with it to get the whole thing rolling, but an important part of the initiative was to embed the issue of loneliness into all government departments, such as transport, education, and so on. I want to pay a particular tribute to Jo Cox. Jo Cox was a UK MP who really championed the cause of loneliness. But unfortunately, and very sadly, she was assassinated by a right-wing extremist. but we, in the UK, we really thank Jo Cox for the work she did in improving this knowledge about and understanding of loneliness, particularly in older people. Of course, it's not just governments that have a role. Everyone can play a role in connecting and collaborating to tackle loneliness. So going from the top anti-clockwise, employers have a role in setting the right environment. Then at the bottom, local authorities and public health services have a role. In yellow, the voluntary sector has a role. But most importantly, friends, families, and communities have a pivotal role in trying to improve this very important issue. Now, it is important to understand the factors that can lead to loneliness at an individual level. And these factors might include social and cultural influences on the left, the identity and personality of the individual, the situation that the individual finds themselves in. And then in the middle, there are events or life stage triggers, like we mentioned before, such as moving to a new town, losing a job, or losing a loved one. And then on the right, there are personal thoughts and feelings. For example, is it something to do with me, or is it external? Is it within my control? Is it likely to last? And all these factors contribute to the experiences of loneliness. This slide summarizes the essential elements in tackling loneliness. At the top, what's important is a person-centered approach with peer support. Then as we go clockwise, there has to be accessible and affordable transport, a localized approach, an approach to destigmatize the issue of loneliness, increased knowledge of resources in the local area, and actually developing a better range of resources in the local area. And then partnership working, mobilizing the community to tackle this issue. And of course, collaboration and co-production of services between different agencies. All these elements are important. Now, in our hospital, we were particularly interested to see how common was this problem of loneliness in our patients, both in outpatients and also inpatients. So we did a couple of surveys to look at this. So firstly, in outpatients, we looked at the Falls Clinic and the Bone Health Clinics, and it was a cross-sectional survey, and we used the ELSA one-item questionnaire, as well as the more complex De Jong-Gierveld loneliness scale. And this last scale also helps to distinguish between the two elements of social loneliness and emotional loneliness. So we looked at 108 patients with a mean age of 72. Using the ELSA questionnaire, 34% of people described loneliness some of the time, with a further 2% quite often. And using the De Jong questionnaire, 27.8% had social loneliness, with about a half having emotional loneliness. So it was a problem in our general outpatients. What about inpatients for older people? We did a very similar survey, and this was looking at geriatric wards in a large teaching hospital, and we looked at 6 geriatric wards. Again, we used the ELSA single item questionnaire, but we also used the De Jong-Gierveld and the Campaign to End Loneliness measurement tool. What we found was actually quite revealing. So using the single item questionnaire, 40% of older inpatients described loneliness some of the time and 17% quite often. And across the 3 scales, the percentage reporting some degree of loneliness varied between just under 60% to just over 80%. And interestingly, the De Jong questionnaire also described that almost two-thirds of people had social loneliness and 2/3 had emotional loneliness. So the conclusion from our 2 studies was there was some degree of loneliness present in over 1/3 of the Falls and Bone Health Clinic patients and over half of the geriatric ward inpatients. So we feel that a comprehensive geriatric assessment now should mandatorily and routinely include inquiry into loneliness in our patients. I want to just present some data from around the world, particularly during the pandemic. Of course, during the COVID pandemic, the need for for distancing has actually increased social isolation and loneliness. And there are some initiatives from around the world which are worth looking at. These are data from South Korea, and they have looked at an intervention called social prescribing in rural areas of the country. And this intervention was based upon either music storytelling or a self-help group or gardening groups. And you can see from the data that in the intervention arms, there was a lower prevalence of loneliness, there was a higher prevalence of social participation, a higher prevalence of self-esteem, and a lower prevalence of depression. Now, another very interesting finding from a study in the United States has looked at this interesting concept of purpose of life. Now, we know that during the pandemic, because of social distancing, isolation increased. This particular study examined this concept of purpose of life as a psychological resource that may buffer against loneliness. What this study found was that higher loneliness levels generally were associated with a lower intention to maintain social distancing and protective behavior. But this link was not present if there was higher purpose in life. And what it also showed was that having a higher purpose in life was associated with a lower prevalence of loneliness. And I think this concept of purpose of life does need further exploration in general in our understanding of loneliness. I also wanted to show this study from Turkey, and this looked at the effect of perceived social support. So it's not just having social support, it's how the person perceives it and whether they find it useful. So you can see from this study that there was a positive correlation between perceived social support and self-care ability, but there was a negative correlation between perceived social support and loneliness. So I've been through a very quick summary of what loneliness is, how to define it, how to measure it, the adverse consequences, and strategies to try and deal with it, including, I think, the support of politicians and funders to help alleviate this very important issue. I'm going to end by a saying from Mother Teresa, who, of course, was a very famous nun, which I'm sure you will all be aware of. And she quoted that the greatest disease in the West today, and I actually believe across the world, is not TB or leprosy, it is being unwanted, unloved, and uncared for. We can cure physical diseases with medicine, but the only cure for loneliness, despair, and hopelessness is love. I thank you for your attention, and I'll be happy to have discussions and answer any questions at the end of this session later on. Thank you.
Next speaker is Professor Karen Andersen Randberg, that will give a lecture on using digital health to embed geriatric medicine in primary care. Professor Andersen Randberg, please.
Thank you. Hello, everyone. My name is Karen Andersen Randberg. I'm a geriatrician from Denmark, and I'm going to give you a talk on using digital health to embed geriatric medicine in primary care. People are born as copies, but age differently. However, we have diverse organizations of healthcare, which also influences the way we age differently. I'm going to present you some studies that we are doing in a welfare state like Denmark. In Denmark, we are benefiting from a tax-funded welfare state where we have both hospitals, community healthcare, and primary care physicians, which are free of access to patients of all ages. It is free, and nobody has to pay anything to have these services. What is especially well developed in the Nordic countries and many welfare states is the home care system, which is part of the primary care sector. It is run by the community. In Denmark, it's the municipalities, and they are responsible for delivering care to community nurses and by community nurses and care workers to older, vulnerable people. Those are the ones you see in the triangle here in the middle. Why should we have digital health? Well, it is actually for the sake of both the patients and the healthcare providers. We all know that we will have more and more older people, especially the 80-plus-year-olds. For the EU 27, you can see on this graph that the number of 80-plus-year-olds will increase with almost 100% over the coming decades. Also, we know that if we are too late to discover or recognize symptoms of an illness, it may proceed to become more severe and lead to acute admission. And for the patient, it may also lead to adverse health outcomes, such as dependency and drops in functional abilities. This has been shown very nicely by Clegg and his colleagues in this article in Lancet in 2013. Another thing which is more for the society is that we are having seeing the problems by having declining fertility rates, as we have fewer people in the working force to work for older people's sake, and especially in tax-funded systems, but especially also that we will be lacking the hands of these people to help solve the problems by an increasing aging population. When we talk about geriatric adults, we are talking about the vulnerable older adults. And by the green arrows you see on the side, I'm looking at those older people who are really in need of care. I'm not talking of those who are able to take care of themselves, but the other group is quite large, and it becomes larger with increasing age. So we can try to find out some ways to deliver digital health to the patients. We can also try to find ways where we can support informal caregivers, that is family members, but also formal caregivers. In this case, in a welfare state, it would be the community that delivers, or the municipality that delivers the healthcare on a daily basis. Also, to support primary care physicians, which will also be there will be few of them in the future. And finally, also for outpatient clinics in the hospitals, if in case we have some complicated treatments that we would like to monitor while the patient is still at home and without needing an inpatient stay. One of the big challenges when you want to be out early and recognize symptoms at an early stage and be just on time for starting treatment is that the older you get, the more common it becomes with atypical symptoms. And that delays treatment, initiation of treatment in the older adults. But this can actually be overcome by, of course, increased knowledge to the home carers or healthcare workers that works with older people. They are not necessarily taught this, and in many cases, we have those with the shortest educational level taking care of these elder people, and they are actually those who are in the up front when an older person gets ill. So they need to be taught how to look and identify atypical symptoms. Other things we can use is machine learning imposed on electronic care records. And we can also use digital health in in-home assessments and for clinical decision support tools. I'm going to give you some examples here. This is a machine learning tool that we have developed. We have previously published a paper where we could see that an increasing need for health home care by the municipality was something that would be could be seen in a few weeks before an acute admission. And now, as we register the delivered home care, and that is done in minutes per week, we can actually find out whether there is an increased level of care delivered, and this will flag. This will give a flag to the nurse, home care nurse or community nurse that can go through the municipality care record and actually do a nurse assessment using a decision support tool. This is registered digitally, and maybe she thinks that it's a good reason for it. For example, in this case on the slide, it could be that this is a person receiving normal health, normal home care, but now suddenly she had she broke her wrist and she needs some increased help, and then it is normal to have an increased level of care. But in other cases, there's no clear explanation, and the nurse would go through the care record to see what is going wrong this way. We need to address this and see if we can support her in some way, or make a medication review, or perhaps contact the GP or the primary care physician. We can also try to do early recognition of emerging disease in older adults with these vague symptoms or atypical symptoms. A community nurse may be called out to a care receiving older person because exactly one of the usual home cares have seen some signs which may be an early warning of something going on. So the community nurse goes out and does a systematic assessment. And here the word systematic is very important because they go through observation of pulse, temperature, respiration, consciousness, and systolic blood pressure. And there's a scale over here on the right side, which actually helps them make a decision for whether to contact a primary care physician or not. They also use the point of care technology, which can be both measuring blood pressure, but actually also doing blood testing with some bedside analysis for dehydration, for example, electrolytes, creatinine, leukocyte, and CRP for infections. Then they can use their tablet to inform the primary care physician, and they upload all the data they have received from the point of care technology and the systematic assessment. And this helps to support the clinical decision making by the primary care physician. If all is good, the primary care physician says, okay, it's fine, check later again, or the primary care physician can decide to start treatment at home, or eventually an acute admission if it's really bad. We can also try to add focused lung ultrasound, and this is where we want to address, and this is where we use ultrasound in trained community nurses who have been trained to do this ultrasound on site. It has been shown that lung ultrasound is actually at least as good as X-ray on the thorax to identify pneumonia. But in this case, we are in a randomized controlled study looking at whether we also can reduce acute admissions for pneumonia, which is some of the most common reasons for being admitted acutely. We also have the possibility of post-discharge joint hospital community follow-up visit, and this is where we discharge patients from the geriatric clinic actually are visited by a geriatric hospital nurse who knows the patient from when he or she was staying in the hospital, and together with the community nurse that comes home in the patient's home and goes through an assessment of all bodily functions together with the patient. So how are you doing now? Are you eating properly? Are you drinking properly? Do you are you feeling bad? And if there is a reason for the geriatric hospital nurse to think that there's something wrong, she may do the objective assessment as you saw before the community nurse could do, but in this case, the geriatric nurse has the same equipment. She can do the blood testing. She can also do a video call to the geriatrician on call in the department and telling what's going on here, and maybe it's going the wrong way, and maybe we need to restart treatment, preferably at home, or if needed, we can always readmit the patient to the ward. Finally, there's also the possibility of doing a video conference between the geriatrician and the primary care physician, for example, if advanced care planning is needed, which it very often can be. People are born as copies but aged differently and in different organizations of healthcare. That is what I said in the beginning of my talk here. But we must remember, even though I showed you the data or some studies that are ongoing in a Nordic welfare state as Denmark, digital health actually also increases the use, the possibility to be used by people in other states which do not have the same welfare state system as we have. And it is it can be used wherever smartphones works. So it actually can be used to lower the inequality in health in older persons. So don't forget to also think of it maybe in more rural and less developed areas of the world. Besides a revolution and an evolution, I believe firmly that digital health is a cultural reform in healthcare, and you should all try to go for it as soon as possible. Thank you.
Good afternoon. If you are in Argentina, or good night if you are in Japan or in Europe. Thanks to all the three speakers. We had three wonderful lectures. And again, if there are any questions, please you can write in the Q&A button. And in the meantime, I will just start asking Professor Masood, what can the society can do to combat loneliness that, as you explain, is a very big problem in the elderly?
Okay, thank you, Mario. It's a good question. So I think the politicians and government have an important role here. So like I said in my talk, in the UK, the government had a strategy and appointed a minister for loneliness. But I think lobbying groups can do a lot. And societies such as ours, for example, gerontological societies, the geriatric society. So in the UK, the BGS, for example, we worked very hard at lobbying politicians to try and do something about this. So for example, we held events in Parliament, we organized seminars, we invited politicians to attend those so that they basically learn about the consequences of loneliness, what a problem it is, how costly it can be. And just by persisting with this lobbying, I think we can get politicians on our side and try and invest some money and invest in time to try and deal with this. So I think that's something that certainly we can do as societies.
Thanks, Professor Masood. And Professor Strandberg, you want to say something on this?
Yes, thank you, Mario. Yes, Professor Masood already said very important things about prevention of loneliness and how to intervene. I would just like to add that in Finland we have made some research on intervention studies about that, and so-called circle of friends has been developed.
I think you
folks who are sort of they are facilitators who.
While in the meantime we get back to Professor Strandberg, I will ask.
Okay. Are you listening?
Carry on, Timo. Tell us about your intervention study.
Yes, circle of friends has been sort of developed and validated also in Finland to prevent loneliness in small groups, and it has been now sort of distributed in Finland, and John Morley has been very enthusiastic about that, and I think he has also in St. Louis, the United States, he has been doing something about that. But anyway, loneliness is a very important thing, and we should be doing something about that. Thank you.
Thanks, Timo. I was asking to Professor Karen Andersen Ramberg about digital health. Because I think that digital solution may be very important from one side, from the even for loneliness in some way, and for surveillance of older people. What do you think society can do on that? Because also there is a problem of cost, and they are not very implemented. I do believe. What's your
I am I know there exist already today some digital tools which is operated by your television, because although you have WhatsApp and you have Skype and you have all these different things that you can connect to other people, it's not as easy for people to press the different buttons on a tablet or whatever. But they're used to their TV. They know the channels. They always know where to press. And if you have one button that will link into a common room where you can see your friends that you are linked up to, then I think there's an opportunity there also to reduce loneliness for those who are disabled and it's difficult for them to get out.
And what about surveillance, communication with relatives?
Well, that can be done also via the TV screen. I know of a program which was developed by, it's probably exists in many cases, but I know a Danish product where you just operate this from your, so a lamp comes up when your daughter is online, you could say, is on a television, and then you can just push the button on your TV screen, and then you see your daughter because she's online. So that exists already. So it's just a matter of getting it out there for people to know. And I know they are doing a lot for it right now.
Okay, thanks very much. I do believe this is a very important subject that probably in the International Society of Geriatrics we have to discuss more, because digital health is very important to help elderly people, to combat loneliness, to combat also to help the surveillance of older people. And I would like to ask to Timo, Professor Strandberg, the same question I asked to Professor Massoud. What the society can do to improve the healthy aging? Timo, I think you are on mute.
Yes, yeah, very important. I think big problems in societies and Western societies especially, and also in Asia and elsewhere, is the obesity epidemic, and as a consequence of that, diabetes is increasing, and it has all kinds of dimensions to vascular health and vascular disease, and of course that's very important. And I think prevention of obesity and diabetes, it's sort of a society issue. If you are fat already and obese, so it's very challenging to improve the situation. Of course, we have now some drugs and bariatric surgery and so on. But anyway, I think societies, it's very important to promote exercise or physical activity at the population level, and also the weight management and healthy diet and so on. So I think they are societal issues as far as prevention of obesity is concerned, and also for hypertension, I think salt reduction at the population level is important. It's just one example. So I think that they are very important for society to realize that it must be done at the population level. We have very good experience in Finland from the North Karelia project and so on, but okay, society is important. Thank you.
Thanks very much. There are probably a comment from Professor Masood we have 2 minutes left, so 1 minute each.
Yeah, I was just going to ask Timo. Timo, do you think the government can play a role in promoting better eating habits or physical activity habits? I'm just thinking, should they perhaps give the poor part of the population some free membership to gyms and things like that? Is that possible?
Yes, of course it's possible, but it's a matter of choices, what the society will do. And of course, I think there's been at the EU level, there have been discussion about tax on sugar, tax on hard fats, and tax on salt. But I think there are also legal issues, and it's from a jurisdiction, it can be difficult to do. At least lawyers tell me that it's not so simple. But of course, that there are, and of course we don't. But tobacco smoking, that it's possible to prevent smoking by legal procedures.
Yeah. Professor Karen.
Yeah, very quick. Just one comment. I talked about atypical symptoms in older people, but we should also be reminded of the atypical depression, and the atypical symptoms of depression in older adults. Not many people are aware of this, so it's really important that we teach people about the atypical symptoms of depression. That was all I wanted to comment.
Thanks very much. We have just a few seconds just to close this section. I have just the time to thank all the 3 speakers, because we had 3 fantastic lectures on 3 subjects. Probably we let deserve one symposium each, because what we discuss, healthy aging, digital health, and loneliness, are very important subjects in geriatrics medicine and in gerontological research and clinical issues. So I want just to thank Professor Masood, Professor Standberg, Professor Andersen, Ramberg for this participation, for these wonderful lectures, and goodbye to
thanks
all
for
the
the
audience.
chairman. Thank you.
Thank you. Thank you, Mary.
Bye-bye.
Thank you.